those of you who don't know me, I'm a dentist at One Community Health and the head of our continuing education department. I want to give a huge and very grateful shout out to our sponsors that made this event possible today. Thank you so much, GC America, Elevate Oral Care, Capital Dental, Advantage Dental, and the Columbia Gorge Health Council. Let's quickly give them a round of applause. Dr. Frachella boasts an impressive 45-year career in dentistry. He's worked in the public and private spheres all across the states, and he still lectures over the largest residency program at NYU, right? Okay, better mess it up. He is widely recognized as a national leader in the use of silver diamine fluoride and SMART technique, for those of you who don't know, silver modified atraumatic restorative technique. Please put your hands together and give a warm hood welcome to Dr. John Frachella.
Okay, thank you everybody. Thank you for coming. This is going to be formidable for me because there are so many of you. We're going to want to do a hands-on somewhere this morning, hopefully, maybe after the break. But there's a lot of material. So the last couple times that I gave this talk, time before last was at University of Buffalo in the dental school. And that was very uncomfortable. And it's not, Chris Kammer was there and Jerry was there. And I had some other helpers too. But, you know, I think we did a great job and the reviews came back. And, you know, and I get these, you know, the forms back because they send them to us, right? And everybody loved it. And they said it was like the best ever. But now those people who were mostly residents and some department heads and some profs in that school at UB are having a very hard time. And I only found out yesterday from Dr. Dion. So this isn't comfortable stuff, people. You know, if you've come here to get warm and cozy, it ain't gonna be that, all right? And then the last time was at NYU, and that was supposed to be, you know, a 1 or 2 month effort. They gave me an AV team, and I'm working with Brooklyn here, you know? And it's like, holy cow, this is crazy. Because there's, you know, what the job was do this in 4 modules and make it MMC, Medical Management of Caries, and do it in 4 different modules, okay? And then the residents, and we're talking 400 residents. I mean, in UB, we maybe had 50 people in the room, maybe 40, 50, you know, but 400 folks from all over the world that are participating electronically, virtually, and they're in 5 different disciplines of residency. And I can't do this in 4 modules at, you know, 45 minutes a module. So I said, maybe I can do it in an hour a module. And they said, well, the residents will never sit there for that long. They aren't going to sit there for 4 hours and hear you talk. Well, I was able to do it, but an hour and a half per module. And the evaluations came back yesterday. And this isn't about me. I'm going to say that repeatedly. This is not about me. It is about them. The evaluations were like the Buffalo evaluations. They really, really liked it. Okay, I was between 75 and 100% yes, plus all that stuff that you filled out these things as I have course evals. But it's the criticisms I wanted to hear. So the number 1 criticism was, it's just too long. You bet it's too long. This is going to be way too long, so get ready, okay? All right, number 2. Why can't he split it into more parts? Because if I split it into more parts, there'd be 16 instead of 4, and 4 is enough, all right? And then the 3rd criticism was the most important one. Why didn't you put him on at the beginning of our residency instead of at the end? And they were pissed. The residents felt ripped off. Why? Because, and this is our comments, you sent us to your clinics, NYU clinics, and we did not do this, and we should have been. Wow. I'm just sharing that with you. I only learned it yesterday. So, again, please don't shoot the messenger. I'm just the messenger. We are blessed today to have some really, really heavy hitters here, super important people that have made what I'm going to say possible. People like Dr. Doug Young, people like Chris Kammer, Sarah, Steve Duffin at this table, and many others. We've got Ashley Danielson, we've got Crystal with us, we've got all kinds of wonderful folks here who have been doing this for a long time. We've got Ashley, who's been doing this since 2015, am I right? And she's not a dentist, all right? Since 2015. I know a hygienist who is an independent hygienist in Maine who has been doing this since 2009. And it has not been pretty for her. She's been challenged by every dentist and the Board of Dental Examiners and everybody, but she stands strong. She does it in schools, much like Ashley. If you get a chance to talk to Ashley or any of these people, and Crystal included, please, everyone, and Sarah, let them share with you what their experiences have been. We have an RN with us today, and he just came back from the Congo where he was teaching and performing SMART, and he's not a dentist. Okay? And he was trained by a dental therapist. Jerry Boschman is standing in the corner here. He's a dental therapist, and he has been doing SMART, and he has been using glass ionomer atraumatically all over the world, successfully. If they were hurting patients, you would already have known about it. So this garbage that we're getting from the boards of dental examiners and from the dental societies is exactly that. It is garbage. It is exactly the kind of attack that individuals like myself receive are from dentists who think that my license should be removed. And when they go after my license, they find that the FDA is saying, wait a minute, he hasn't hurt anybody. Until he hurts someone, we can't take his license away. But I would just want you to keep that in mind. It doesn't necessarily make friends or influence a lot of people. But if you influence a few, especially if they're young and they're residents, we might be able to change this thing. I'm not in this game for changing this slowly. I want this to change fast. And I want it to change fast for one reason. Not for me, not for my practice, because I don't have one, not for anybody's practice, and not for anybody's pocketbook either. I want this to change for the children who are getting hurt. And that needs to stop. Okay, so let's get started. There's a lot of stuff here. Let's go. Next slide, please. Okay, who I am is far less important than who you are. Dentists, please raise your hand. All the dentists? Oh, okay. We have more dentists than I thought. Wonderful. Hygienists, please. Oh, wow. All right. Dental therapists? Any other dental therapists besides Jerry? No? Okay, Jerry's our only one. All right. Dental assistants, please. There's our majority. I had heard that. Thank you for coming, all of you. Okay, how many use silver diamine fluoride? Hands, please. Ooh, vast majority. Okay. How many use glass ionomer? Good, good, good. A little less than silver diamine fluoride. How about anybody here that is using glass ionomer and silver diamine fluoride before they do any drilling? Wonderful. Okay, good, good. Who refers patients to pediatric dentists for hospital surgery and/or in-office sedation? Good. All right, thank you. Can I have just a rough idea of how many a day, a week, a month? Colin? One a week. Next one, whoever else did? Raise your hand.
2 a month.
2 a month. Becca?
Maybe one every other month.
One every other month. Okay. Well, I'll tell you what, that's a whole lot better than Buffalo. Remember that, Chris? We asked that question in Buffalo, and they all raised their hands. In the pedo department, these are pedo residents. Every single pedo resident raised their hand. And I said, well, you know, and they were sitting at a table like this. They were round tables. And I said, well, someone choose your leader. And they pointed to one guy. And I said, well, how many? And what did he say, Chris? Like something like, it was lots. Lots and lots and lots a week. And I was like, what? And they go, well, that's what they tell us to do. We're in school. We're residents. I said, yeah, but you're dentists too. Yeah, but we're residents, you know. And we got to refer to the hospital, and we got to spend time in the hospital. And then one of the leads in the restorative department said, I don't have time to teach this, John, because my kids, my residents, kids to people like me, my age, excuse me, my residents aren't on site to learn it. They're all in the hospital. Oh, holy cow. All right, thank you. Next slide, please. Now we know who we are, right? All right, almost every slide you're going to see today has an attached scientific reference. It had to for the NYU talk. I couldn't just spew this stuff out because I knew it from my friends like Dr. Duffin and like Dr. Young, okay? They told me this. Oh, yes, I did a paper on. No, I had to come up with papers. So there's scientific references on every one of these slides, okay? I'll cite many papers, clinical trials, and peer-reviewed studies, more than you probably care to read about. I have brought 4 textbooks. Please don't walk away with these. But they are what I would consider, if you read, and not everybody reads, I'm well aware of it, but if you actually read books, I would suggest reading this book by Graham Mount. They're here. You don't have to copy this down. You can come up and look at these. Please don't walk away with them. They're not going to do you any good anyway because they're all annotated on the sidelines, and my notes are in here, okay? This is an Atlas of Glass Ionomers by Graham Mount. This was recommended to me by Dr. Young when I first started studying under him on glass ionomers. I still consider it the Bible, and I know he does too. His good friend, Dr. Hien No, has a chapter in here that should not be missed by anyone. This is brand new. That's old. That's like 2000. I think I have a 2002 edition. That's the latest. And Graham Young has passed. He's not even with us anymore. And this is Dr. Jeff Knight's new textbook on silver, fluoride, and glass ionomer cement. So this is smart. This is a smart book, okay? And it just came out. You can get this on Amazon. This is Dr. Graham Craig's tiny little book that is invaluable, because this man has been doing smart since 1978, and we had no idea. We thought we had invented it. Whew. That was a smack in the face. And this is Dr. Duffin's book with many authors. I don't know how many authors we have in here, probably about 40, huh, Steve? How many? 30 authors and about, 100 or so or more references in the back. But, you know, people sitting in this room have chapters in here, and it's our smart book, okay? I would say if you went through all 3 of those, you'd have a good crack at it. Okay, let's get started. Go ahead. Okay, terminology first. Caries is a microbial biofilm disease that can't be removed by instruments, but it can be managed by diet. Notice diet. Notice diet. Did I say diet? That's the first thing. But it's a thing that we all pretty much ignore because we're dentists. We're not nutritionists. Well, except me, and maybe you. I have a degree in nutrition, but I don't get a chance to say it enough. So I'm going to say it again, diet, and then behavior and communication, and then removal of biofilm, and then using silver ions and fluoride ions. I didn't say silver and fluoride, did I? I said silver ions and fluoride ions, because what you're going to hear about next is about ions. Now, pathological changes in microbial biofilm are directly related to sugar. Diet again. Changing the diet changes the disease. Don't ever forget that. 90% of all living things are microbial. Trees, whales, frogs, humans, clouds. We would not exist if it were not for microbes. Without us, microbes would do just fine. Caries is caused by an imbalance in microbes. That does not mean that microbes are bad or that we should try to kill them all, or we would kill ourselves. Microbes laugh at us when we try to drill them away. They laugh. Dr. Duffin has more microscopes in his clinic than handpieces, and he has this tiny little microphone, and he puts it by the bugs, and you know what he tells me? He says, "They're laughing, John, they're laughing." Next slide, please. Silver and fluoride ions as medicine. Ions as medicine. I want you to start thinking like an atom, not like a dentist. Think like an atom. Next, please. Okay, here we are. Silver diamine fluoride, it's a colorless solution. Silver ions, fluoride ions, water, ammonia. I'm going to rip through this section because when I asked you who uses silver diamine fluoride, almost every single hand went up in the room. Okay? So I'm not going to dwell. Let's fly through these slides and get to the next part, which is glass ionomer, which we need to spend more time on because we had way less hands than we did on the silver diamine fluoride. So you already know what this is, but I'm going to rip through it just so we're clear on these issues. Okay, next, please. Okay, cleared by the FDA on label for desensitization. That's as true today as it was at the beginning. Okay, it's used off-label to arrest caries. Then FDA gave it breakthrough status as a drug to treat caries. This you may not know about, so I'm going to dwell on it for half a second. What this means is that prior to the breakthrough status, okay, FDA has never ever recognized any substance or action, for that matter, as being capable of treating the disease of caries, including fillings. The federal government does not and never has acknowledged fillings as a treatment for caries, any fillings. The only treatment that the federal government recognizes for caries is silver diamine fluoride through this breakthrough status. I think that's pretty important for you to understand. Next, please. Okay, then the WHO in 2021 recognized it as essential medicine to treat caries. The ADA in 2021 said, we encourage clinicians to prioritize non-restorative treatments based on effectiveness and safety. Prioritize. I should have done that one in yellow. Prioritize means first, as a first measure against the disease, not afterwards, not after the exam, not after you've brushed their teeth or flossed their teeth or do a prophy, but to prioritize. That means first. That's from a paper that Dr. Young and colleagues did in 2018. Next, please. Here it is. WHO essential medicines, where the fluoride is a 1,000 part per million fluoride. This stuff that we'll be talking about from Elevate, 1,000 part per million. You can get it from other companies too, but Elevate has theirs here. Glass ionomer cement and silver diamine fluoride are 3 essential medicines. Next, please. There it is again, essential medicines. This is the paper, 2021 executive summary. Next, please. In 2022, the AMA created a medical code for SDF. That's a CPT code. That is for medical teams. The American Medical Association approved this new category code for the application of SDF by medical teams, which is why I was so thrilled to have Luke with us, because he is a part of a medical team, not a dental team. Okay? Previously, only dental care providers could apply SDF. SDF is no longer for use by dentists only. It is supported by the ADA, the ADHA, National Dental Association, and the Society of American Indian Dentists, and the Center for Medicine Advocacy, among many others. This goes live in July, guys, which is why I was hoping, since this is all for an FQHC, where Colin and Becca work, I was hoping that they would send some of the medical staff over, okay? Now, I don't know if we're there yet, but I hope we get there. Why? Because who sees your patients first? Who sees the dental patient first? The medical does. They see them when? At the well baby exam. Then when else do they see them? At the immunization. And then when do you see them? Long after that. And then they've already got caries, and they wouldn't if we went as far upstream as we can possibly go with SDF and essential medicines. And that is the take-home message from today. You can go home now. Go upstream. Far upstream. If you found pollution in a stream, what would you do? If you found pollution in the Willamette River, those of you who live in the valley like Doug, what would you do? You'd go up that river and you'd look at every single stream pouring into that river, and you go high into the Cascade Mountains until you found that pollution that was polluting your water supply and killing you and giving you cancer and killing the fish and hurting your supply of food, wouldn't you? Why don't we do that with caries? Okay, next please. What it does is it detects. First and foremost, it detects. It detects better than a dentist can detect. It detects better than a hygienist can detect. It detects better than anybody can detect. If you apply it, if there's a question in your mind, no matter what kind of provider, no matter who you are, is this or is this not caries, you apply silver diamine fluoride, and if it turns black, guess what? It's caries. Whether you like it or not, it tells you. It arrests CDT code 1354. It remineralizes, it desensitizes, and it prevents caries. And you can use that code, D1355, when you chart that. And you should use that code because you're preventing, and we'll discuss how it prevents. Next, please. The medicine part is ionic. Look, ladies and gentlemen, ions are electrically charged atomic particles, and all life is electricity. All life is electricity. This is just life. We're just talking about life, and we're talking about ions. Next, please. Here are ions inside bacterial mitochondria as seen under the microscope of Dr. Steve Duffin in Kaiser, Oregon. Next, please. They're tiny atoms from which an electron shell has been lost. They're small enough to pass through the walls of bacterial cells. They are in the trillions in just one drop of SDF. They are not the same as metallic silver. They are not the same as silver particles, colloidal silver, or nanosilver, all of which are much too large to pass through bacterial cell walls. Next, please. Okay, they perforate bacterial cell walls in contact. They bind to essential cellular apparatuses. They stop bacteria from performing even the most basic of functions. There are some out there who say they don't kill the bacteria. Well, we sure as heck have evidence that they slow them way down. They slow the bacteria so far down that the bacteria are relatively impotent, if not dead. Okay, next, please. Okay, silver ions also remineralize by building structural support inside arrested caries lesion. Okay, remineralized structural reinforcements are created by silver nanowires within SDF arrested decay. These silver nanowires that you see here are from silver penetrating 1 millimeter into sound dentin. Next, please. Fluoride ions act against bacterial and remineralized tooth structure. SDF contains almost 45,000 of them in parts per million. That is concentration, not dose. Okay, fluoridated water has 0.7 parts per million. Fluoridated water is wonderful. But, you know, relative to the caries epidemic that Luke saw in the Congo and that I see every time I go to Maine, you know, fluoridated water is like using a squirt gun against a forest fire. I'm sorry. It doesn't even come close. What kid drinks water in Maine? They don't. All right. So fluoride ions in SDF don't enter the bloodstream. Fluoridated water, and the fluoride ions in fluoridated water do, but not in SDF. That's important to know. This is topical only. Okay, next please. Each ion, both the fluoride ion and the silver ion, are highly reactive against caries-causing bacteria, as well as highly reactive with minerals inside teeth. Reactive with the minerals that are already there. Next slide. Mechanisms of action. Obstruction of dental tubules. Immediately, if I had to do this slide over today, I would make that in yellow. Immediately decreases sensitivity, penetration of enamel 25 microns, indentin 200 to 300 microns. Antimicrobial inhibits biofilm adhesion, penetrates bacterial cell wall, and it's selective. It doesn't kill them all. It doesn't even inhibit them all. It just, we don't know why. It inhibits the ones we want inhibited. It's like, huh, wow, what a surprise. It's like, thank you, Mother Nature. And it remineralizes. It structurally occludes those dental tubules, and it converts something into something else. What? Hydroxyapatite into fluoroapatite. Duh, have you heard this before? Why do you use fluoride? Why do you use topical fluorides? Why do you use fluoride varnish? None of this is new to you. You know the chemistry. You have been using this chemistry forever. Recognize that, please. You're changing one substance, natural substance, into another natural substance, which is more crystalline and hard and more acid resistant, therefore less decay. All right, next, please. Oh, by the way, immediately. Did I say immediately? Because let me tell you what. When we start doing SMART and you start excavating and you say, boy, that's a deep one. Oh, look at the x-ray, that's a deep one. I think I'll take the needle out. Why don't you do this instead? Why don't you take the micro brush out and touch it to that lesion and get immediate desensitivity without a needle? What, you don't even have to wait for it to take. You don't have to sit there and go, boy, I need like 45 minutes or whatever for this thing, you know, and I didn't get it. Oh, I didn't get it, you know. I wasn't near the foramen or whatever. Okay, so SDF turns lesions black, okay? Black staining equals caries detection. If it's applied to a questionable lesion and it turns it black, then it's carious. It diagnoses the caries. Next, please. Okay, some people recommend sodium diamide fluoride with potassium iodide. Is anybody in this room using potassium iodide? Raise your hands. Okay, then I don't need to say this. Let's just rip through this. The reason for this slide is that it burns. Go ahead, next one. That's what potassium iodide Revastar does. Revastar's got some new products out. You know, they've recognized this. This will be off the market, I'm sure, soon enough. Okay, next slide, please. Okay, commonly asked questions. Do you want to use it on anterior teeth? And the answer is no. It's not necessary to use it on anterior teeth. You can use glass ionomer on anterior teeth in the smile line, and you can get pretty much a similar result. Maybe not identical. You don't get immediate desensitization, but you get some desensitization, and you get remineralization and an antimicrobial effect. And I'll give you all the references on the antimicrobial effects of glass ionomer. Okay, when we apply it to posterior teeth, can the stain migrate to the front teeth? Yes, it can. If you're concerned because you don't know if that's caries in the anterior, and you don't want to put silver diamine fluoride on it because you don't want to turn it black because the mom doesn't want it black, the kid doesn't want it, whatever. Nobody wants it black. Then what you can do is you can protect those anterior teeth with fluoride varnish or with Vaseline before applying the silver diamine fluoride to the decayed posterior teeth. Will SDF stain sound teeth? No. SDF stains in any teeth are removable and or can always be made white later. Always be made white later, very simply, and without needles and without drills. Go ahead. Okay, now this is an interesting study in Australia, 2015. We have strep mutans growing on human dentin on the left, and we have it dead after application and then one reapplication of SDF. The point is, these teeth were being soaked in a sugar solution for literally a week before the tests were done, and then re-soaked again for another week. And what you see on the right, the dead strep mutans, is after being SDF, only one application of SDF, and then the teeth got placed back in the sugar solution again for another week. So it just shows you the lasting effect. And why does it have such a lasting effect? Because silver diamine fluoride has a zombie effect. Okay, silver ions stay inside of dead bacteria, poised to attack new bacteria in the future. From the journal Nature, 2014. And I have found as a pediatric dentist that there is not a kid on the planet who doesn't want zombies in their teeth. They all want zombies in their teeth. Zombies are cool, in case you didn't know it, okay? Ask any kid. Next, please. Okay, chlorhexidine does what SDF does, but it also kills microbes on contact, but it does not stop microbes from returning. In other words, it doesn't have a zombie effect. No zombies with chlorhexidine. That's why it's not as good. Okay, next please. Okay, this is one of the more important slides I can show you. Those are dentinal tubules, and those are microbes, and that is tooth structure, dentin, that has been drilled down to white. And those microbes are giving that dentist the middle finger because drills don't kill these guys. They laugh at them, as Dr. Duffin has proven with his little microscope. They laugh at dentists with drills. So if you want to be laughed at, keep drilling them. But you're a joke if you do, because that doesn't kill them. You're drilling for another reason than killing them or treating the disease. That's altogether different, and that's fine. Maybe you have a cosmetic practice, and you need to do this for cosmetic dentistry, for bonding, or for whatever. That's okay. But don't do it thinking that you're killing bugs. Next, please. Okay, silver nanowires, back to those. Okay, this was from a paper that I did with Jeremy Horst and Joe DeRisi, that silver nanowires hint at a mechanistic explanation for a clinical method to actually harden caries dentin. We hypothesize that silver diamine fluoride may not only achieve its antimicrobial functions through biochemical interactions, but also through an inherent ability to integrate into dentin structurally. And you will see the rebars. Go ahead, next slide. There they are. These are rebars of silver in dentinal tubules. Dentin is porous, like wood, okay? And when you use something like polyurethane on wood, it goes into the pores of the wood deeply, okay? And that's what silver does. It goes into the pores of the dentin, and it solidifies, and it's structural. Next. Okay, here it is. This is these are x-rays from a dentist friend who did this work on his son. You're going to see this in part 3 and part 4 also, this same slide, because it's so important. Because Dr. Duffin and others, including this dentist, kept writing at one time, we don't do this anymore because we already know, that what we're seeing here, you know, you might want to look at your screen on the side, it shows it even more clearly. You know, you see this line right here. You know, that is a vertical line of protective SDF remineralization. From a cavity, look how close it is to the pulp, and you see it in both places, these vertical lines of remineralization. I remember the first time I saw it, I was surprised. I know that the first time Dr. Duffin saw it, he wrote me and said, have you ever seen this? And I sent him these, and I said, yeah, Peter said the same thing. We keep seeing it over and over and over again. It's not one case. It's not one patient. And this being in a place that's hard to get, that isn't self-cleansing, you know? Okay, next one. Okay, remineralization lasts even when the stain is removed. That doesn't, you remove the stain, you don't remove the demineralization. You remove some of the zombies, but not all of them. Okay, next. Okay, SDF depends on a bunch, its effectiveness depends on a bunch of stuff. So I call SDF a dependent drug, a dependent breakthrough drug. It doesn't work every time in every case unless you address its dependencies. It depends on proper application. Notice I put that as number one because I see so many people applying it improperly, okay? The addition of maintenance doses. I see that so often. I applied it, doc. Well, how many times? Once. Duh. Okay. Reducing substrate exposure. Remember, diet, diet, diet. Change the diet, you change the disease. Okay. Facilitated lesion cleansability. You know, if the lesion isn't self-cleansable, it's not going, you're going to need to reapply it more, and you're going to need to apply it properly more and more. Additional combination therapy. SDF depends upon additional combinations of therapies. And the addition of more silver and fluoride ions from other sources. So combination. Combination therapy is better than single agent therapy. If you know, that should be your mantra. You don't do one thing, guys. You got to do as many as the patient and the time and the money allows. Do them all. They combine. They're synergistic. Next. Okay, dependency number one, proper application. Understanding capillary action. Dry sugar cubes. The greater the density and depth of each sugar cube, the longer it takes for the underlying liquid to saturate up. Each lesion is different in density. You know that because you've drilled into them. You've poked into them with sharp explorers. I don't want you to do that anymore, but you know what I'm talking about. Some are super dense, and some are like, whoa, they're like going through rotted snow. You know, it's like your ski goes through the rotted snow and you go over the tips, right? I mean, it's just whoop, rotted snow. You know, and some is real nice dense snow because it's been packed down. The SDF penetrates each of those densities at a different rate. And your goal is to get it to the floor of the lesion. So it's got to penetrate all the way through. So how long do you wait for it to penetrate? Well, sometimes a patient only gives you 30 seconds if you're lucky. And sometimes they'll give you 2 minutes, and sometimes you need to take that time. Go ahead, next, please. So we need to thoroughly dry saliva from lesions and isolate before applying SDF. Why? Because if they're saturated with saliva, the capillary action doesn't work as well. Do you understand? If it's already saturated with something thick, like saliva, which is a mucopolysaccharide, then the SDF, which is very thin, can't penetrate in. It's as pure and simple as that. You got to make it dry, and I mean dry, 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 and that can be a challenge, okay? In some patients, you just can't make it dry. They're just too spitty, and they're just not well behaved enough. Apply it anyway. Get it as dry as you can, okay? Next slide. This is in your handouts. I'm not going to go through it. It's a how-to page. Dr. Jeremy Horst and myself and Laura Sackett, an RDH, and a graphic artist, and I did these playbook pages. They were supposed to be something that CareQuest was going to publish, and I have finally been given permission to give these to you. I suggest that you laminate them and bring them into your operatory and share them with your patients and share them with the parents. So we don't need to go over this now, but that's the how-to. Next, please. Okay, how do we get it approximally in between teeth? You got to isolate, then you can apply with super floss or with a microbrush. I don't like the super floss. When I use floss to apply it, it always ends up running across the kid's cheek and they got a brown streak, which is temporary, by the way, and which can be removed with a slurry of salt and water, so it's no big deal. But I'd rather avoid that phone call. Oh, he's got these lines across his face, blah, blah, blah. Okay, don't apply compressed air or the SDF will spread where it's not needed. Tease it between the teeth. I just put it on the marginal ridge, and sometimes I just tease it with a little bit of floss or just let it seep through. You know, if I really wanted to get through floss, yeah. And sometimes I go through the papilla. I just dry the papilla and just go, you know, I know it's there, and just get it, put it on the marginal ridge and put it in the papilla, and it's going to come, the two capillary actions will work together and they'll meet each other. You know, it's a thin liquid. Just think about it that way, you know. Okay, next. Okay, this is interesting. I think, Steve, this was your slide. The SDF on the distal of L also arrested an originally undetected lesion, mesial of K, that was noticed only after L exfoliated naturally because we'd put SDF on it, right? Next, please. Cardinal rules of SDF application. Remove saliva and plaque first. Isolate and dry lesions when completely saturated with SDF. Then completely saturate with SDF. Never rinse SDF after applying. I hope we're over that, you know. Oh my gosh, that was awful. Would that take about 5 years until we finally got over that thing? Well, because John Featherstone and UCSF, you know, were afraid that if we didn't rinse it off, it'd somehow or other hurt the patient, which it doesn't. Okay, reapply it in the same way in as many appointments as necessary until lesions turn dark and hard. Okay, if you want to see a peer-reviewed consensus paper on it, there's the link down below. That's a paper that Dr. Young and I participated in writing, a detailed explanation. If you need a detailed, which it sounds like you don't because you're already using it. So let's move on. Okay, next. Dependency number 2, reapplication. Okay, so reapplying, you all know this, silver diamine fluoride and fluoride varnish, much more effective than just diamine fluoride with no fluoride varnish. Examples from research, we've got all kinds of examples. Okay, next. Frequency, in mild risk patients, 2 times a year, every 6 months. In high risk patients, every 3 months. Okay. It may take 1 to 2 years of repeated SDF and fluoride varnish applications to get full caries arrest in some cases. It's important to know that. That is rather extreme, 1 to 2 years, but it may take that long. So be persistent, okay? Next, please. Okay, this is the part where the nutritionist comes in and, you know, change the disease, you know, change the diet, change the disease. I don't have time. You know, I just teach, don't sit. You know, I mean, I sit the kid down and with the mom right there, and I tell them point blank, I don't have any time. I'm seeing 50 patients today. I've got to get you out of this chair fast. What is your poison? And they all balk. And I go, no time to balk, no lies, no holding back. I don't have time for this. You don't have time for this. What is your poison? And you get them to say it. You get them to say Red Bull. Well, how many Red Bulls? I don't know, you know, 1 or 2 a day. And the mom rolls her eyes and you go, Jimmy, how many Red Bulls? Describe to me how many Red Bulls you had today. Well, I had one at lunch, Dr. John, and then I had one at the afternoon break, and then before soccer practice I had one, and then I got benched, so I had another one. 4? 4, great. Chug them. What? And the mother is like, no, I mean you crack it and you, no sipping, dude, chug. You will end up dead, but you will be an exquisite corpse. People will not be coming to your open casket saying, oh, who is his dentist? They're going to say, that must be Dr. John's. At least be an exquisite corpse, for gosh sake. And they laugh like you laughed, and I got them. As soon as I do that, I go, what else? And usually it's gummy bears or something else sticky. In Maine, it's atomic warheads. Maleic acid. It bites through teeth like nothing I've ever seen before. It just makes holes faster than drills. It just ruins teeth. and I try to get them to substitute. They're already hooked, guys. They're hooked on sugar. I am not an addiction counselor. I'm sorry, I don't have time for this. But I explained to them, if you take a Hershey bar and you put it on the dash of your mom's car in the hot sun at 89 degrees Fahrenheit in Maine or anywhere, what happens? And the kid says it melts. Well, guess what? Your mouth is 98.6, and it's going to melt there, and it's going to go where we want it, which is in your stomach, and it's not going to stick on your teeth like those gummy bears do. Replace your bad snacks with better snacks. That's critical. So, chug, don't sip, replace bad snacks. I'm out of here, dude. Open your mouth, SDF, see you next time. Or glass ionomer, see you next time. I don't have any more time than that as a nutritionist or as a dentist. But those are I'm just giving you my little tools. It works. Because they walk out of there saying, he wants to kill me, Mom. I'm going to start chugging. Next time you see the kid, well, how many are you doing? I'm down to like 1 or 2. It's hard to chug those, Dr. John. Yeah, I know it is. Yeah, I'm glad to see you're still alive. And they get it. And then, of course, I try to encourage them to drink water afterwards. If you can just take a sip of water after you drink that crap, your teeth are going to be a lot better off. Your stomach isn't going to be any better off. You're doomed, but whatever. Okay, next. All right, then lesion cleansability. We've just found that if we can go and clean out these lesions, see down at the bottom where we have a cleaner and a trap, it's less of a food trap, and then most likely to arrest in the upper left there, and then medium, and then least likely, and then medium. You get the point. The more accessible, the more self-cleansing it is by the patient's tongue and his saliva. Go ahead, next slide. All right, combination therapy. Okay, SDF alone combined with others. Okay, maintenance doses. Apply SDF fluoride varnish afterwards. Apply 5,000 part per million toothpaste. Very critical, very critical. Reduce caries-causing substrates like crackers and sugar. Add better home care. Add glass ionomer. Okay, we're going to talk more about this in the third part. Go ahead. Okay, for those of you that are still disbelievers or need more proof, go here. There's your reference. There's your citation. That will give you 100 cited articles on silver diamine fluoride, all in one quick look. Okay? Done. Don't need to go over all these papers. Next, please. Here are some of the most important recent SDF studies. Go ahead. Okay, this is an interesting one. It helps prevent ER visits. This was by Dr. Scott Tomar, was one of the lead scientists on this one in pediatric dentistry, March of 2020. Dental emergencies were approximately 80% lower in the SDF group. I like this slide because of what it says about dental emergency appointments at the emergency room of our hospitals, but I also like it because it's Scott Tomar, who's the guy who wanted to take my dental license away when he found out I was using SDF before it got FDA approved. He compared it to sheetrock from China that was falling off his walls in Florida. How can you use that stuff? It's probably just like that sheetrock I put in my house that's falling down. It's not even approved, blah, blah, blah. Okay, and they went after my dental license and didn't get it because the FDA laughed at them. But anyway, next. I'm glad Scott's on board. That's why I show it. Thank you, Scott. Okay, SDF reduces general anesthesia and hospitalization. Gary, you'll recognize this slide. This is from the folks at Advantage and Sherry Ludwig, and this showed that Oregon hygienists over 9 years of early intervention in schools using SDF glass ionomer and providone iodine, which we're going to be talking about, reduced general anesthesia by 75%. That's from 2020. Next, please. Okay, more evidence. We've got 88% reduction in referrals for dental general anesthesia with SDF, and that was from Australia. Yarway and Hedge, Yalware. A great study, 144 were asymptomatic, 102 2 patients chose SDF over dental general anesthesia, and 100 of the 102 were successfully managed with SDF versus dental anesthesia. Next, please. Okay, nothing in dentistry has ever been 96% effective against caries. But the foremost cariologist in the United States of America, Dr. Margarita Fontana from Michigan, did a study that shows that SDF and fluoride varnish together, what we call the Duffin method, not just silver diamine fluoride alone, but silver diamine fluoride with fluoride varnish, can give us as much as 96% prevention against the disease. Okay, next please. This is also from Dr. Duffin, his studies in Ecuador, Ghana, and Bolivia that are showing success rates of between 99% and 71% after 12 months. Okay, next please. And here are those tubules. And this is immediate. It doesn't have to turn black and hard for this to occur. As soon as you apply it, that's what happens. They occlude. You can't see through them. Suddenly everything becomes hard. It becomes denser. Okay, that's where your desensitization comes from. That's the effect on the pulp, and it's within 0.5 millimeters of the pulp. That's pretty close. That's half a millimeter to the pulp. Excuse me, doc, you shouldn't even be that close to the pulp. What are you doing there in the first place? But even if you are, and you apply SDF, that's what happens. Okay, it plugs dental tubules, and it forms a protective layer immediately, which oftentimes prevents your need from having to give local anesthesia. Next, please. Okay, it can be used for indirect pulp treatment. It is indirect pulp treatment. It is IPT. You can charge for IPT. Okay? Cower study and the Gupta study. 2 great studies, one in 2011, one in 2015. Next one, please. Okay. Most recent RCT showing that SDF affects the pulp favorably. Silver diamine fluoride demonstrated capacity to protect the pulp in this series of 277 teeth with very deep decay. It was successful in managing peripulpal caries with asymptomatic clinical outcomes. That's from 2021. These are all references that negate concerns about SDF pulp irritation by boards of dental examiners from Vermont to Oregon. We have these boards of dental examiners that are saying, we can't have hygienists do that. We can't have Ashley do what Ashley does. She's going to hurt someone. She's never hurt anyone with SDF because it's protective of the pulp. It is not irritating to the pulp. And we have the evidence to prove it. So when the Board of Dental Examiners say that, tell them that they are literally in the pseudoscience area. That isn't science. This is the science. Show them these studies. Next, please. Safety. 2 studies show safety. One in 2019, one in 2012. There is no measurable systemic absorption of SDF into the human bloodstream when it's applied properly. Show your Board of Dental Examiners that, will you please? I'm trying to show them. They don't want to see it, but they're getting it. Okay, next, please. Patient acceptance. I just love this study because it shows 73% of patients in New York City preferred SDF treatment over drills and needles. That's the Montefiore study. There are many other such studies. I just cherry-picked this one because I like it, because I think of people walking around in New York and dentists in New York wielding drills. Go ahead, next. All right, key messaging to patients and parents, and I find this critical. I tell them these words. This is an antibiotic liquid. I tell them it desensitizes, it remineralizes, it controls decay. I tell them it must be reapplied regularly, not just once, Mom, I'm sorry, you got to come back. Okay? It is a combination medicine, and I compare it to triple antibiotic cream. And I say to the parent, remember when you used to use Neosporin? Yeah, I do. I don't find that on the market anymore. Yeah, I go to Rite Aid and they don't have the Neosporin. Why? Because they've got triple antibiotic cream. What does that have in it? It has Neosporin, but it also has bacitracin and polymyxin. And why all three? Because combination therapy is better than single agent therapy. Duh. That's why we've got silver ions and fluoride ions together in the same medicine. It stains decay black, but it doesn't stain healthy teeth, Mom. It prevents decay. Stain decay, any stain decay, can be made white later. Yes?
So can you, it's okay, people are probably hearing. So can you provide clarification on number 5 when you say silver fluoride must be reapplied regularly? Because what if you're doing SMART that day? And you're doing SDF with glass ionomer, what is your interpretation of continuing to apply SDF regularly?
You mean on that same tooth that you're doing the SMART on?
Yes. Or are you using it generally as a preventative?
I'm using it generally as a preventative. Thank you. Yes. Generally as a preventative, it needs to be applied and reapplied and reapplied. Why? Because of the other factors that are dependencies, especially diet and behavior. Okay, so when you got that kid whose diet you know is not improving, and he's still eating the gummies, et cetera, et cetera.
I think she's asking if it's restored, you don't have to reapply the SCF versus if it's not restored.
Okay, if it's restored, you don't need to have to. If it's not restored, you should apply it, but that's not always so either. On that particular tooth that I've restored, okay, if I've only done, say, a same-day SMART, I might reapply silver diamine fluoride, after I've done my same-day SMART at the next appointment, depending upon all of the other factors. No one kid is going to be the same, and no rule of thumb applies across the board. It depends upon their behavior. And that changes over time as they mature, right? I mean, they're going to, hopefully start coming around. They're going to be chugging and not, they're going to be chugging and not sipping, et cetera, and eating better sugars than stickier sugars, whatever. Okay, next, please. Okay, so in public health and in private practice, go ahead, let's rip through these. Puts the fire out. SDF puts the fire out, and that should be the very first thing we do, is to put the fire out, okay? Go ahead. Okay. This is a private practice in Vermont. This guy's name is Johnny Norris. He's got like 15, I got it 9,000 patients on the slide right now. He's got 15,000 patients now. He just moved into Maine. So he's in Maine, Vermont, and New Hampshire, and he sat through one of these. Isn't that awful? Don't you pity him? Poor guy. And I never met him. And this was in Vermont. I never met this dude. I talked and I talked and I talked till I was blue in the face, just like I'm doing now. And then I hear about this guy. And he says to me, hey, you changed my life. I said, what? I had no idea. Who are you? What are you talking about? He goes, I got 15,000 patients. I'm doing this now in your state. I'm in Maine now. Huh? And he goes, yeah. He says, this is what we're doing. Mike Shercliffe and Peter Milgram just got back from visiting him because they couldn't believe what they heard, and they wanted to see this. He and a friend of his were in pedo residency. They heard me. They were just finishing up. And they were talking about opening up separate practices in Vermont. And they said, well, we're going to open up our practice, and then we're going to get a chair, this many number of chairs, and we're going to have this many number of drills. We're going to have this many number of staff. And they said, why don't we just not get chairs and drills? Why don't we just do what he's saying? That'd be a lot easier. And what do we have to lose? We don't have anything invested. So they started doing it. And they are going gangbusters. And he just contacted me last month and asked me if I could get on a Zoom call with the Vermont Technical Institute School of Dental Hygiene, and we are going to have this program in a hygiene school. It will be credentialed as this is credentialed. This is an accredited course through the AGD. I'll answer your question in a second. Through AGD, you're getting CEUs for this, okay? I want hygienists to get these CEUs in their hygiene school. Let's start there with this course. And for gosh sake, I don't need to go to Vermont to do it. Johnny Norris can do it. All he needs are these slides and this syllabus. And then it should change. Because as our data changes and as our information changes, it should change. But we're going to have this in a hygiene school in Vermont starting this fall. Go ahead, Doc.
The practice on the slide here, 7% Medicaid, I was curious what type of Medicaid. Is it a reduced fee for service? Is it capitation? With it?
It's not capitation, it's reduced fee for service, you bet. Yeah, that's how it is in New England. Yeah. I mean, you know, I don't know if you know how fortunate we are to be in Oregon by comparison to being in a place like New England. It's absolutely Neanderthalic there. It is so slow, and there is so much resistance. It makes us, makes us look like the progressives that we are. I think we should be very, very proud of ourselves. And very proud of our organizations like Advantage that support this, and Capital Dental that supports this, and the
Others that are supporting this talk that we wouldn't be having today, and Elevate, and GC America. This is very, very, very important that we have these sponsors. I can't emphasize that enough. Next slide, please. Okay, this
is an example on Penobscot Indian Nation, and the Penobscot Indian Nation on Indian Island, Maine, in Old Town, Maine. You've probably heard of Old Town canoes. That's where I come from. I come from that area, and I'm connected to this tribe. And this is a white dentist, not a native dentist. His name is Ned Robinson. And I said, Ned, you were at my course when I talked in Maine. What's going on? And he said, children and adults on Indian Island afraid of needles and drills allow SDF application 99% of the time, John. And I'm telling you, this is a tough population. Our Native American population is hard to serve. You guys know, I see heads shaking. You know what I'm talking about. This has saved the island. And these people on this island are my people. And I'm just so happy that they're willing to return to Dr. Ned to have this medicine applied and reapplied. Next slide, please. Okay, here's an example of the Hawaiian Islands. I was asked by the Hawaiian Pediatric Dental Association and then by the Hawaii Dental Association to please come and speak about medical management of caries. And my lead, my host, was Dr. Lynn Fujimoto, who is the Hawaii Academy of Pediatric Dentistry president. And I asked her before I came here today, how's it going? She said in 2019, we had 184 patients that were leaving all of the islands and going to Oahu to be treated in the hospital in Oahu. This is at a very big cost, to fly Island Air to Oahu, to go under general anesthesia, to have their teeth drilled and filled. And she says now, 2020, we've got 47 due to increased use of SDF. I feel vindicated. Thank you. Next one, please. Okay, in 2019, an Australian study on the outcomes of SDF used in indigenous communities says a community trial of silver fluoride treatment for indigenous dentition caries in remote indigenous communities, 2019. Fluoride, it was sodium fluoride, silver fluoride, excuse me, was well accepted, easy to use, and at least as effective as ART. And they had stats on that. Whoa, that's pretty interesting, because now we've got a bunch of studies that are comparing SDF and ART. And we're going to talk about ART later, but that's just glass ionomer and no SDF. Of course, I'm a belts and suspenders kind of guy. Why not use both? But it's interesting how we're finding a similarity between SDF and just glass ionomer as single agent therapies. And I'm not supporting single agent therapy. I'm just saying it's interesting to see that we've got that similarity. Go ahead, next. Okay, this is Shishmaref, Alaska, in a native village. It's a barrier island, 50 miles from Russia. And Dr. Mark Kelso invited me there to teach his team about SDF, and he says it works well on preventing the need for some Class 2s. Dentists visit our remote villages only 1 week or 2 weeks annually. I don't think he heard when I said reapplication, did he? I said reapply, reapply, reapply. Next slide. So here's what I found when I landed in Shishmaref. It's about the size of a sheet of paper, this island, by the way. It's a barrier island. They're losing it daily because of global warming. And as the oceans rise, they're losing their native lands. And on the left side of the screen is the trash can in front of the only grocery store on their island. And it is filled with with containers that had sugary drinks. And on the right side of the screen is the Coca-Cola that we brought in the hold of that plane to fly from Nome to Shishmaref. And what? Once, 1 week a year, 1 to 2 weeks a year, and you think silver diamond fluoride is going to work? No, you're not honoring its dependencies. Next, please. When dental teams can't be present in remote public health sites, train community caregivers, nurses, midwives, medical assistants. Delegate healing. Next, please. So how are these two analogous? On the left is an iron lung used to treat polio, and on the right is a dental handpiece used to treat caries. Next. Both are mechanical approaches to microbial diseases, but neither treat those diseases. Iron lungs were replaced by antimicrobial medicine, just as drills feared by some patients are now being replaced by SDF applied with microbrushes. Mechanical versus medical. Medical is less expensive, less invasive, more preventable against epidemics like polio and caries, which are caused by microbes. Next, please. Why are duodenal ulcers no longer surgically amputated, and how does that relate to drilling? When I was a kid growing up near Buffalo, New York, everybody who had stress seemed to have ulcers, and they all went to the doctor to get their ulcers cut out, and then they all eventually got stomach cancer and died. A lot of my relatives, okay? We discovered that duodenal ulcers are caused by bacteria, as is dental caries. The bacteria in the stomach ulcer is H. pylori. Bacterial infections are best controlled with medicine. After a 20 to 30-year fight, the treatment of stomach ulcers with non-invasive antibacterial medicine versus surgery became acceptable. Our hope is that dentistry will stop treating dental ulcers, which are caries, with surgery as a first measure. Next, please. SDF fits well into healthcare reform and value-based care. Value-based care is measured by health outcomes compared to the cost of delivering those outcomes. Healthcare reform is about value-based care. Dentists who become value-based providers by adopting SDF now will be far ahead of those who don't. Next, please. Caries isn't a fatal disease, yet a significant number of children have died while receiving treatment for caries in ORs with general anesthesia and in dental offices due to reactions to sedations. More often than not, they're treated with sedation and general anesthesia because some dentists consider them to be developmentally delayed and thus behaviorally unmanageable. Next, please. Okay, in 1985, Dr. Martin McIntyre, a colleague of ours who lives in San Francisco, was faced with the problem of a 1-year waiting list in the OR for pedo patients in a hospital in Saudi Arabia. Every 15 minutes, he treated 2 unmanageable children, and he actually removed them from the waiting list by using medicine while it took many hours for his colleagues to treat them in the OR surgically. Within 1 month, the OR waiting list was empty, and the patients were asking why this hadn't been done before. And then he was fired by the company that had hired him because the dentists couldn't handle it, because they wanted to go to the OR because they're dentists and they were trained to do so. So they made sure that he got lost, which he did. 40 years later, the pandemic has delivered this to the forefront. OR time is now in scarce supply. What treatments do dentists provide phobic children and special needs adults while waiting for OR time? Next, please. Before requiring more access to the OR, shouldn't dentists and their professional organizations seriously reflect on why patients need the OR, GA, or in-office sedation when other dentists have learned that there's no need? Next, please. Children who receive dental general anesthesia remain at high risk for developing new caries. They still exhibit harmful plaque accumulation and gingival bleeding, and this was proven in this 2022 study. This just came out. Okay, following dental general anesthesia, primary and permanent tooth decayed, missing, filled, treated scores at recall visits were significantly higher than those at baseline. Children who underwent dental general anesthesia demonstrated more teeth newly affected by dental caries than those who received no dental general anesthesia, with an 11.4% of the dental general anesthesia kids needing dental treatment under dental general anesthesia again. Repeat, at the rate of what? $7,000 to $10,000 per kid, straight out of your wallet, straight out of your tax dollars. The wrong thing for the wrong reasons, hurting children. Next, please. I like this quote from Jeremy. I love this quote from Jeremy, so I'm going to use it. The only scenario that necessitates general anesthesia, sedation, restraint is the limited skill of the dental team. Behavioral, psychological skills are more advanced than sedation and general anesthesia. It's unfortunate and hopefully temporary that our dental education system completely fails in this regard. Read the book by Milgram et al. Called The Treatment of the Fearful Child Patient, and the paper by D'Amato and Milgram in 1999 compare behavioral outcomes, these books compare behavioral outcomes between young pediatric dentists with sedation to seasoned pediatric dentists without. Same outcomes. Sedation and general anesthesia is mostly a crutch. Now, I will make an exception for my colleagues like Dr. Young, who is sitting here and does general anesthesia cases wonderfully in the hospital on patients who truly medically need it. But it is overused by the pediatric dentists to whom you refer. I'm sorry, you refer to these, and at least the case is so in Maine. I'm not saying it's specifically the case here in the river, okay? So personally. But in Maine, I see the general dentists referring to the pediatric dentists. They're doing so because the kid cried in the chair. That's appropriate behavior, okay? And what I do in that situation is first and foremost ditch the chair, okay? Do me a favor and sit in the other chair. Let me have this one. Sit with me right in front, right like this, knee to knee. Sit, 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 knee to knee. Okay, this is your kid. Your kid is crying. And what do you say? First thing you say is, stop crying. No, Dad. That is not cool. It's fine for the kid to cry. And I put a hand on the kid, and I go, this is wonderful. Okay, Dad. Okay? Boom, like this. You're holding the hands. No, the head is here. You're holding the hands. You're holding your kid's hand. And she's crying. And you're saying, I'm sorry. And I'm saying, ignoring the crying, saying, Dad, what are you sorry about? This is perfect. She's the best patient I ever had. Look at her mouth is wide open. You're wonderful, I'm saying. And she is screaming her head off. And you are loving her. You are loving her. You've got your elbows are on her knees, are on her shins, and your hands are on her hands, and her head is cradled in my hand like this, perfectly safe, just like this, okay? And what's going on, yeah, let's turn this way. So we're just like this. Ditch the dental chair and the damn dental unit. This right here is how you're doing it. Okay? Her mouth is wide open. I've got an assistant over there, hopefully. And if I don't, you're my assistant. And we're going to dab that mouth dry as best we can. And we're going to paint. And then I'm going to do this. And you're going to hold. And I'm going to say, Dad, that's the best dental patient I ever had in my whole life. She's so wonderful. And then you're going to turn her towards me, and I'm going to, she's still crying. She's scared to death of me. And I'm saying, sweetheart, you are the best there is. Now, go back and sit, please. Here's where it all fails. So I walk in to the operatory. And because they say, oh, Dr. John, you're needing operatory number 3. So I walk into operatory number 3, and there's a kid. As soon as I walk in the door, starts screaming her head off. Of course she does. I just came in scrubs. I'm the guy. He's the man! Ah! You know, and what do? You know? Well, the first thing I do is say to the dental assistant or the hygienist that did that, what are you thinking? Why would you do this? You couldn't tell that this kid was going to cry? Please try to assess these patients better. Get her out of the chair immediately. Suddenly the kid stops crying. The kid's like, huh? What, we're playing musical chairs now? Yes, get me 2 straight back chairs. Well, we don't have any in this operatory. Well, then get them out of the waiting room. I need 2 straight back chairs. And then I do this. And the kid starts crying again. And I say it's perfectly good. And we get the work done. And I do smarts that way. And I do SDF that way. I do everything better without a chair than with a chair. Because chairs are scary. And the first thing I tell the patient is, do you see a needle and a drill? I don't see any needles and drills. Get up and take a look. I don't see anything here. I had an Explorer on the tray once. And the dentists, this was in Maine at an FQHC, were like, you're never going to be able to treat this kid. And they all walked away from their work to stand out in the hallway to watch me get shut down. And I could see them. They had the door a crack, and they were all saying, what's he going to do with her, you know? And she was fine. I couldn't believe it. This little 12-year-old girl, she sits there. She was just the greatest ever. And I said, how are you? Great. I said, hey, you mind if I look in your mouth? She says, no way. And I said, why? And she points to the tray. And I said, what is it about the tray? You know, and there's an Explorer and a mirror there. And I said, is there something on there that bothers you? And she just shut down. She just got stern like this. And I picked up the mirror, and she didn't say a thing. I picked up that Explorer. She started screaming, and she bounded out of the chair. She just got right out of the chair. No way, she says. And I said, whoa, whoa, whoa. Hang on. Calm down. I said, here. And she held it. I said, what do you want to do with that? And she said, I want this gone. And I said, then make it gone. She went, threw it behind her. I said, great. You want to get back in the chair? She looks over in the corner. She looks back on the tray. She doesn't see anything. She goes, fine. She sits back in the tray. We did an exam. We did 4 smarts. She was perfect. Something is causing that fear. Remove it. You don't need it. Don't stack that tray full of drills and needles and expect that kid not to cry. Okay? That's this message to me. Okay, next, please. I think this is the last slide. Yeah, that's my laugh a minute slide. The Maharishi Mahesh Yogi. Okay, we'll go to everybody, a little bathroom break, maybe a drink, and then let's get to part 2. Okay, thank you. We're not gonna take it. We're not gonna take it anymore.
Let's play some geography.
Okay, everybody, we ready? Let's get going.